Hello guys, good day. Today I'm going to talk about fetal distress. What are the causes? What are the signs and the like? Firstly, before anything else, let's define what fetal distress means. Fetal distress is an emergency pregnancy, labor, and delivery complication in which a baby experiences oxygen deprivation or birth asphyxia, causing changes in the baby's heart rate. Fetal distress can also result in decreased fetal movement and meconium in the amniotic fluid. Medical professionals like nurses must immediately address and manage fetal distress to avoid HIE or hypoxic ischemic encephalopathy and permanent injury. Uh, Fetal distress is commonly confused with the term birth asphyxia. Birth asphyxia occurs when the baby does not have adequate amounts of oxygen before, during, and after labor. This may have multiple causes, some of which include low oxygen levels in the mother's blood or reduced blood flow due to compression of the umbilical cord. Hmm. Now, let's move on to the causes of fetal distress. The following are just few underlying causes of fetal distress. These are abnormal fetal presentation, forceps and vacuum extractor misuse, placental abruption, preeclampsia, prolonged and arrested labor, umbilical cord problems, uterine rupture, and many more. Moving on, what are the signs of fetal distress? May include changes in the baby's heart rate as seen on a fetal heart rate monitor, decreased fetal movement, and meconium in the amniotic fluid, among other signs. Uh, in this part, the nurses must immediately address and manage fetal distress to avoid serious complications such as hypoxic ischemic encephalopathy, just like what I've said a while ago, HIE, uh, cerebral palsy or CP in short, and other birth injuries. Mm, Expectant mothers aren't always with their physician when signs of fetal distress or so as a nurse. It is important to know the following signs that indicate a baby is in trouble. Often, the only way to stop fetal distress is to deliver a baby, allowing doctors and nurses to administer medical care. This is usually accomplished by cesarean section or C-section delivery. Now, these are the common signs of fetal distress. First is the decreased fetal movement in the womb, abnormal fetal heart rate, abnormal amniotic fluid level, abnormal results of biophysical profile, uh, vaginal bleeding, cramping, insufficient or excessive maternal weight gain. I'll expound these common signs of fetal distress one by one. First is the decreased fetal movement in the womb. Fetal movement within the mother's womb is one of the most exciting parts of pregnancy. Beyond bringing joy to the family, movement within the womb is an important indicator of the baby's health. Some regular pauses in movement are normal because babies sleep in the womb. However, if the baby becomes less active or completely ceases to move, this may be a cause for concern. Uh, the baby's growth might have slowed down, or there could be a problem with the baby's placenta or with your uterus. It's also possible that the baby's umbilical cord could have gotten wrapped around their neck, a condition that's called nuchal cord. Uh, the physicians or nurses should ask expectant mothers about fetal movement and conduct additional testing if patterns are normal. Mm, if you have just noticed a decrease in your baby's movement or you are not sure if your baby is moving less, try counting your baby's kicks over 2 hours at a time when your baby is usually active. If she usually starts kicking after you eat, for example, have a snack and then lie down for a few hours while counting the number of times you feel her kick. But how to increase the movement, by the way? If you're a little nervous and want to prod your baby to shake a leg, you can try a few different simple strategies. First is to eat a snack or drink something sweet like orange juice. Mm, get up and move around. Shine a flashlight onto your belly. Talk to your baby. Push or poke or pat gently at your belly where you can feel your baby. Next is the abnormal fetal heart rate. Some fetal heart rate patterns indicate distress. To observe an unborn baby's heart rate, medical professionals like nurses can use either an external or internal fetal monitoring device. External monitoring is done through a belt-like device that can be strapped around a mother's abdomen, while internal monitoring involves attaching an electrode to the baby's scalp. In a healthy labor and delivery, the baby's heart rate will drop slightly during a contraction and then quickly return to normal once the contraction is over. Therefore, some variability in heart rate is to be expected. This shows as a jagged line in the monitor. The following fetal heart rate patterns are examples of no reassuring patterns and warrant further investigation and medical intervention. These are an abnormally fast heart rate or also known as the tachycardia, an abnormally slow heart rate, bradycardia, abrupt decreases in heart rate, variable decelerations, late returns to the baseline heart rate after a contraction, or late decelerations. And lastly, in addition to fetal monitoring, an abnormal fetal heart rate may be recognized in a non-stress test or NST in short, or a contraction stress test or CST. Uh, during an NST, a medical professional looks at how the baby's heart rate changes when the fetus moves. A normal NST is called reactive, meaning that the baby's heart rate went up and down as expected. Non-reactive means that the baby's heart rate did not increase enough at times. Physicians may also classify NST results into categories. Uh, Normal, requiring further testing and possibly delivery. An emergency C-section is necessary. Uh, a CST helps to predict how the baby will cope during the labor process and determine whether it is safe to proceed with a vaginal delivery. Uterine contractions temporarily restrict oxygen flow. This is something a healthy baby can tolerate, but it may be very dangerous for a baby in distress. During a CST, physicians record the baby's heart rate in response to contractions. If conducting a CST on a woman not yet in labor, the physician may give her pitocin or synthetic oxytocin to make the uterus contract. It is important to note that there are certain risks associated with this. Pitocin can cause uterine tachycystole, excessively strong, frequent, or long contractions. This can severely restrict oxygen flow to the baby and sometimes leads to uterine rupture. Now let's move on to next, which is the abnormal amniotic fluid level. The amount of amniotic fluid can be determined using a variety of ultrasound methods, including a qualitative assessment, the single deepest pocket or SDP, and the amniotic fluid index AFI. The SDP, sometimes called the maximum vertical pocket or MVP, is the vertical measurement in centimeters of the largest pocket of amniotic fluid that doesn't contain parts of the fetal body or umbilical cord. The AFI is calculated by measuring the depth of the amniotic fluid in four sections of the womb and adding the numbers together. If you'll do qualitative assessment here is fairly subjective. Mm, the ultrasonographer scans the uterus and reports whether the amniotic fluid volume appears to be low, normal, or high, based on their own experience. If there is abnormally low amniotic fluid, this is a condition called oligohydramnios, which can lead to oxygen deprivation and birth injuries like HIE and cerebral palsy. Mm. In addition, a trending decrease in amniotic fluid may also warn of oligohydramnios and should be watched closely. If there is an abnormal high amniotic fluid volume, this is known as polyhydramnios. Polyhydramnios can also cause oxygen deprivation and subsequent birth injuries. Next is the normal results of biophysical profile. A baby's biophysical profile is also often taken if the results of an NST are no reassuring. In addition to taking into account NST results, the BPP includes an ultrasound to assess fetal movement, breathing, tone, and amniotic fluid volume. The non-stress test and each of the four ultrasound parameters are assigned a score of either 0 or 2 points. A total score of 8 or higher is considered normal, unless the 0 score relates to low amniotic fluid. A score of 4 or lower indicates fetal distress and requires immediate action. Mm, uh, Next is the vaginal bleeding. Small amounts of vaginal bleeding are fairly common during pregnancy. However, bleeding can be an indication that something is wrong with the pregnancy. Mm, One particularly dangerous example is placental abruption, which occurs when the placenta tears away from the womb. This causes the baby to be deprived of oxygen, depending on the location and size of the abruption. It may not initially cause fetal distress, but the health of both mother and baby could be still in jeopardy. Likewise, it is important to note that a placental abruption can be present with no vaginal bleeding, but may still pose a serious risk. Placental abruption and other placental problems that cause bleeding require very close monitoring, And in many cases, the mother should be admitted to the hospital and given an emergency C-section. Now, second to the last, cramping. Some cramping is relatively normal during pregnancy. This is because as the baby grows, the uterus needs to expand. However, in some cases, cramping is an indication of something more serious, such as miscarriage, placental abruption, preeclampsia, a urinary tract infection, or preterm labor. Early pregnancy cramps can be linked to many run-of-the-mill pregnancy symptoms, including constipation or increased blood flow to the uterus. Mm, but later on in pregnancy pains could be linked to normal symptoms like Braxton Hicks, contractions, or round ligament pain. It is crucial that nurses appreciate cramping and perform proper tests to ensure the health of the mother and baby. And lastly, insufficient or excessive maternal weight gain. Experts believe that for women with a healthy pre-pregnancy weight, a weight gain of anywhere between 25 and 35 pounds is normal during pregnancy. Mm, the ranges are different for women who were under or overweight before becoming pregnant, as well as for those who are carrying twins or multiples. If a mother gains much less than what is typical, the fetus may be in distress and have a condition called intrauterine growth restriction or IUGR, mm, which means they are smaller than is developmentally appropriate. IUGR mm, requires careful precision, monitoring and testing, and often early delivery prior to labor. Excessive maternal weight gain is associated with giving birth to a baby that is abnormally large, which is which is a condition known as macrosomia. Macrosomia can be very dangerous for a baby. Macrosomia can create a risky birth situation, such as the cephalopelvic disproportion, wherein the mother's pelvis is too small to accommodate the size of the baby's head, or shoulder dystocia, which is when the baby's shoulder gets stuck on the mother's pelvic bone during delivery. Mm, Also, forceps and vacuum structures can cause head trauma and brain bleeds, and labor induction drugs can cause contraindications, I should say contractions, to be so strong, long, and frequent that the baby becomes deprived of oxygen. Moving on to fetal distress diagnosis. Mm, it is important for the physician and nurses to monitor the fetus throughout pregnancy to detect any potential complications. One of the more widely used methods of monitoring is electronic fetal heart rate or FHR monitoring. Benefits of FHR monitoring include the ability to recognize the development of hypoxia by analyzing patterns in the fetal heart rate, the ability to monitor the mother's contractions, the ability to monitor the response of the fetus to hypoxia, a more positive outcome for high-risk deliveries. Nonetheless, FHR monitoring does come with risk as well, including an increased likelihood of having a cesarean section due to misinterpretation of FHR monitoring results. And finally, treatments of fetal distress. The primary treatment used for non-reassuring fetal status is intrauterine resuscitation. This will help prevent any unnecessary procedures. Some means of intrauterine resuscitation include changing the mother's position, ensuring the mother is well hydrated, ensuring the mother has adequate oxygen, and amnio, infusion, the insertion of fluid into the amniotic cavity to alleviate compression of the umbilical cord, and tocolysis, a therapy used to delay preterm labor by temporarily stopping contractions. And lastly, the intravenous hypertonic dextrose. And that's all. Thank you for listening and God bless. Bye.